So I'm just a little confused. Okay, well, good afternoon, everyone, and thank you for coming on this Friday afternoon and to help us kick off this fifth round, shall we say, of MRFTT HIV STI ECHO. I am Dr. Boyce, Deputy Director of the Medical Research Foundation. I want to welcome everyone who's here with us, new and old. Maria, welcome back. And I'm seeing a couple of new names. Thank you for coming.
Thank you.
For doing as well, for having your presence with us. So we're going to discuss briefly, because we wouldn't have had time to go into exhausting detail, the management of HIV drug resistance, because it's a particularly topical now, given that Trinidad and Tobago with Ministry of Health and PAHO are going through our first pre-treatment drug resistance survey, which is something that WHO recommends all territories do, to survey the development of drug resistance throughout their territories, because then that adds important information to how we think about drug resistance in our own territory and what we need to combat. So I will switch to the presentation and we shall get on the way. You just confirm everyone you're seeing the screen. Yeah. All right.
Yes.
Okay, lovely. Thanks so much. So just want to acknowledge the fact that this ECHO program receives funding and support from University of Washington ITech and Project ECHO from the University of New Mexico School of Medicine. I have no conflicts for this presentation. And in terms of learning objectives, I'm hoping to get across today. So we would like to differentiate between the various types of HIV drug resistance, to discuss local and regional burden of drug resistance, to outline some of the factors that contribute to the development of HIV drug resistance, and to discuss some of the best practices for prevention and management of HIV drug resistance. So I think it's important early on to have a bit of a definition of terms. So what is HIV drug resistance, or HIV-DR as it is commonly referred to? So it's caused by a change or mutation in the genetic structure of HIV that affects the ability of a particular drug or combination of drugs to block the replication of HIV, which is what we're able to do with treatment in the first place. And when you think about HIV drug resistance, there are three sort of main forms. There's acquired drug resistance, which is the form of resistance we seem to be most well acquainted with, is the form of drug resistance we tend to encounter mostly. Is that drug resistance that is developed in a person who is on HIV medication but is not taking them correctly, has adherence issues, maybe drug interaction issues that is making the medication less effective, and HIV drug resistance develops in that context. So these are our people who describe as loss of follow-up, or people of poor adherence, or quote-unquote defaulters, which is an older term now, who are not adherent to their medication, who started off with sensitive virus, but because of a poor adherence, develop drug resistance. There is transmitted drug resistance that is drug resistance that is passed on in someone who's ARV naive, who has no history of drug exposure, but who would have acquired a strain of HIV that is resistant to one or more drugs. So for example, someone in the previous category who has acquired drug resistance and who is not adherent to medication, has resistance as a result, transmits that virus to someone who is HIV negative and infects them with that strain of HIV. That strain in their partner will be resistant from the beginning. So they will have transmitted drug resistance. And then there's pre-treatment drug resistance. That is kind of a combination of both acquired and transmitted, right? So this can be in persons who are either drug resistant that is detected in persons who are initiating treatment either for the first time or who are reinitiating first-line treatment. So this will, for example, someone who is on an antiretroviral regimen, stopped taking it for 3 or 4 or 5 months, and restarts treatment and has drug resistance at treatment restart. They would have pre-treatment drug resistance, but as a result of acquired drug resistance. Or additionally, someone who has transmitted drug resistance and start treatment for the first time would also be considered to have pre-treatment drug resistance. And this is the survey that is currently ongoing with, again, the Ministry of Health and PAHO. And just an important consideration to discuss, the genetic barrier to resistance refers to the number of mutations in an ARV's therapeutic target that are required to confer clinically meaningful loss of susceptibility. So, for example, there are some drugs, for example, lamivudine, efavirenz, nevirapine, one mutation and the drug is rendered completely useless due to high levels of drug resistance. And the other medications, for example, dolutegravir, darunavir, where sometimes 5, 6, or more mutations are required before there is enough resistance accumulated such that the effect of the medication is no longer felt against the virus. And one final definition, wild-type virus, which we hear a lot of, and which we will continue to hear, refers to the naturally occurring non-mutated strain of HIV that is pan-sensitive, meaning sensitive to all known HIV drugs. So when we talk about HIV drug resistance, there are several different contributing factors to the development of drug resistance, which are both to the virus itself, to the medications themselves, and sometimes they're patient-specific factors, which we know some about. So in terms of the HIV characteristics, so HIV, when it replicates and makes copies of itself, it's a very error-prone process. A lot of it copies the HIV RNA, but doesn't do a very good job of making sure it's the same copy every time. So you get mutations occurring that some of them may have no clinical impact on either HIV ability to survive or its ability to be affected by drugs. Occasionally at random, you may get mutations which may confer potential drug resistant capability, but those happen very infrequently. But because there are so many HIV variants being generated on a daily basis, it could be as many as, in some cases, 10 to the power 10 variants per day. Even though the replication errors per cycle may not be particularly high, because there's so many replications, you get a lot of variability in terms of the genetic structure of some of the happy variable parts of the HIV gene. In terms of the antiretroviral choice, so especially in some of the older days, early on, the regimens were not very potent. They had a low genetic barrier to resistance, so that it was very easy for the virus to develop resistance to those medications in the face of even slightly imperfect adherence. Remember, there is still this thing that we are taught that 90-95% adherence is required in order to maintain sensitivity to the medications as well as durable viral suppression. So some of the older medications, even some of the medications that are currently in use, for example, efavirenz, nevirapine, lamivudine, still have that low genetic barrier, and one mutation can send the medication into a drug resistant, make the virus resistant to the medication. A long pharmacokinetic tail, meaning that some drugs like efavirenz stick around for a long time. So if someone stops medication today, that medication is in their system maybe up to 2 weeks. The other drugs are gone, they've disappeared from the system, but that medication is still there at levels not sufficient to suppress, so that the virus is able to multiply in the presence of subtherapeutic levels of medication, and that actually causes what we call a selective pressure that tends to not so much force the virus, but tends to encourage the virus to develop resistance to that medication that's still there, almost in a Darwinian sort of way. It's survival of the fittest virus. So the virus that is resistant to the medication is the virus that's going to predominate if there's a level of virus, so when it's not enough to keep it from multiplying completely. In terms of the patient-specific factors, prior treatment failure, obviously, so if someone has been on medication, not taking it well, and has high viral loads, it's altogether possible that those high viral loads are due to development of drug resistance. High pre-ART HIV RNA viral load levels and low CD4 counts. So there have been studies that have shown that there's a greater likelihood of developing drug resistance in persons who have high pretreatment viral loads and low pretreatment CD4 counts, right? And the presence of comorbidities, primarily because, well, for two reasons. One, polypharmacy, there may be a potential for drug interactions, and that's one of the things that we know can affect how well these drugs work, because it can affect the level of the drug in the body. And as well, just polypharmacy sometimes makes people get overwhelmed with the amount of pills they're taking and they are unable to adhere. I was speaking to one of our clients just yesterday or the day before, and he's taking 15 tablets a day. Right? If you add up his diabetes meds, his hypertensive meds, his cholesterol meds, the antiviral, he's taking 15 tablets a day, and he's been, diagnosed since 2009. So for 14 years he's been on these amount of meds. He's a young man, but he's tired. So sometimes these things can lead to poor adherence, but leads to development of drug resistance. And the other things that also tend to favor the development of drug resistance, things like food requirements, which is not so much an issue now, but they are still, there's one drug, I think, Rilpivirine, and maybe some others, where you must take the medication with a certain level of fatness for it to work properly, and that can cause difficulty with persons who may be food insecure. Right? We know that's an issue, especially since COVID, that some people are still struggling to get themselves into steady employment and have a steady supply of food. We spoke about drug interactions already. We spoke about incomplete adherence to medication. Sometimes it's about access. There are some people who can't get $10 to come to clinic because they are destitute, they are impoverished. There are some persons who cannot come to, for example, our location in Port of Spain because they live in gang area A. If they cross that border to gang area B, they might get shot. And those things militate against the ability of persons to collect medication on time and stay suppressed. And we always need to think about psychosocial causes with respect to the ability of people to take medication for depression, anxiety, and persons who just were not able to accept a diagnosis because, for example, if it was they were infected and they were traumatized by the event, so they never accepted their diagnosis. HIV is a trauma to them, so taking medication reminds them of that trauma. There are lots of different factors that predispose to the long-term development of drug resistance. And of course, pre-existing drug resistance mutations, as we spoke about earlier. So I want to just have a little conversation about wild-type virus and resistant virus and how resistance develops. This is from the University of Washington website. So pre-treatment, most viruses, as you can see, are wild-type. But as we said before, the virus mutates fairly commonly during the process of viral replication. So you might get an occasional mutation occurring at a spot that may confer drug resistance to some extent. That these things don't happen frequently, but they can happen. When you start treatment on a suppressive regimen, the levels of virus disappear, not disappear completely, but we suppress to undetectable levels, right? So we will see some of these strains that may be resistant, may be there, but in levels so low that they're not clinically relevant. And similarly for drug-sensitive virus, there will still be levels of virus there, but not at levels that are clinically relevant. And in the face of adherence issues, you would get this suboptimal level of HIV medication such that the medications are no longer able to suppress virus and would favor the development of drug-resistant strains, because those strains are more fit for the environment. They are able to multiply and propagate in the presence of subtherapeutic levels of medication. So eventually, and that is the final square, eventually those resistant strains take over the entire population. Then you will see someone who would have had previously a good initial response have detectable levels of virus that increase over time. And when we speak about how we talk about those mutations are, and we will come to this in clinical case. So the amino acid sequences of the different enzymes that we would sequence in order to delineate drug resistance. So we have the example, the reverse transcriptase and the protease enzyme, the integrase enzyme. They have a sequence of amino acids, and each amino acid has a letter, 20 of them, so L, M, K, V, all sorts of different things. In the wild type strain of reverse transcriptase, for example, at a certain position, there's certain amino acids that we expect to find, right? And for example, in this diagram, at amino acid position 103, there's supposed to be a certain amino acid. I think aspartame. But the symbol is K. And the mutated strain, which is resistant, which confers resistant, it changes from amino acid, I think, glycine to amino acid, and I've forgotten these things now. I checked it this morning. I found it. So the mutations are coded as the number of the amino acid position 103, the wild type amino acid to the left, so and the mutated amino acid to the right. So K at position 103 has changed to an N, right? So you'll see different sorts of things in a clinical experience. We see a K103 and M184B, P225H, and all have different meanings and all confer resistance to different medications, right? Some confer high levels of resistance, some confer low levels of resistance. So putting together a resistance profile will require, sorry, knowledge of these things. I just want to highlight another concept I think is important. So we saw how in someone who is on drug resistant, who has had drug resistant HIV, that they develop a lot of drug resistant strains despite the fact that they're on medication but not taking it. But even if they start taking it better because their virus is not resistant to the medication, they won't be suppressed. Once that person stops medication completely, right, you will find that the wild type strains, because that is the fittest version of the virus in most cases, and that is the version of the virus that can multiply most efficiently, takes over again. But those resistant strains are still lingering in the background, those blue and purplish surface, right? And this is important when we come to resistance testing, and we'll come to that again, right? But you'll find that when you restart medication, the wild type goes away, those resistant strains still continue to multiply in the background. So what's the global burden of HIV drug resistance? So this information is taken from the 2021 WHO HIV drug resistance report. And it states a couple of important things. That one, in 16 out of the 20 countries that reported on this, the nevirapine and efavirenz-based regimens are still the most frequent regimens in use. And pre-treatment drug resistance to those drugs is more than 10% in 21 of 30 countries that reported in drug resistance. The reason why that 10% threshold is important is that once you cross that threshold, there's a real danger that the success of your treatment program is in peril. Because you now have 1 out of 10 persons coming in for care for the first time being resistant to the drugs you're putting them on. Right? So if you're aiming for 90, 95% suppression, we can't have 90%, 10% of persons coming in potentially resistant to the drug. And this speaks to the need to change other combinations, and particularly one of the things that WHO is telling us to do is to switch to dolutegravir. It's one of the newer drugs, has a high genetic barrier to resistance, few side effects. So many resource-constrained locations, as well as even those areas where we have the benefit of more resources in terms of availability of drugs and the funding mechanisms to afford those drugs, are switching to drugs like dolutegravir and drugs in that class. Now, the rate of nevirapine and efavirenz resistance is 3 times higher in people who are restarting after a period of interruption than in people who are starting for the first time. We can expect that, right? If you stop the medication and maybe you have been adherent to the medication, there's a chance that you develop resistance. So by the time you've started back, you're already resistant to the drugs you're starting back on. So the difference is 24% in people who are restarting after interruption versus 7% in people who are starting the medication for the first time. There's only one country who reported some level of dolutegravir resistance. That was South Sudan, which is useful because dolutegravir resistance, if that becomes a serious issue, can really again get us to a point where we're in peril, or the success of our treatment programs are in peril. And the resistance of to drugs like tenofovir and MIVD, which are other drugs that are used in treatment of HIV that pair with drugs like efavirenz, nevirapine, dolutegravir, and as well as are used in pre-exposure prophylaxis. Thankfully, those rates are low. So there's still a good chance of success of PrEP because the background resistance to the drug we use in PrEP is low. So this is taken from a 2019 HIV drug, the same HIV drug report, but in 2019. The reason why I chose this, you will see in the next slide. So we have various countries in South America, in Africa, in Asia, reporting that their rates of drug resistance to drugs like nevirapine and drugs like efavirenz and other drugs. And it ranges from less than 5% in Vietnam in 2017 to a high of 25, 26% in Honduras in 2016. So these are very high rates of resistance, and one of the major reasons why we should start switching to drugs like dolutegravir. In 2018, sorry, in 2022, we actually did a report to WHO in terms of what our drug regimens look like, and 86% of the persons who are on first-line treatment, right? Of the 44, 35 people on first-line treatment, 86% of those are on drugs like efavirenz and nevirapine. Why that's important is we would have done a survey in 2019 of 99 persons who started treatment ARV naive, meaning they're not on medication, they're not reinitiated, right? They started medication for the first time, and fully 31% of them were resistant to any drug, and 26% of, no, sorry, 29% of those were resistant to drugs like nevirapine and efavirenz, right? So we actually, sorry, we are worse than Honduras in 2016, right? And the data is relatively contemporary, 2018, which is 2016 and 17. That's why I chose this one as opposed to more recent, right? And how do things look like in more developed territories? So, for example, in the US, in the last a 5-year survey in 2014 to 2018 showed that, you know, their drug resistance rates, so any class, there's between, let's say, 18 and 20%, as opposed to ours, which is 30. And nucleoside resistance is like 10 to 12, non-nucleoside resistance, 6 to 8, sorry, the other way around. Nucleoside resistance, 6 to 8, non-nucleoside, about half of where we are. And this is primarily due to the fact that the US and some of the territories started with protease inhibitors first, then went to integrase, and triple was non-nucleoside, sorry, were not used predominantly for some time. And these are just some of the major mutations you see in the right part of the chart, where you see in K65R, which gives resistance to drugs like ADT, the R263 and Q148 give resistance to integrases, and M184 gives resistance to lamivudine and emtricitabine. So when do we suspect possible HIV drug resistance? Well, generally in two scenarios in the context of antiretroviral therapy, either what we call incomplete virologic response, which is to the left, where treatment is started, you get a response, but you don't get it down to undetectable level. You don't get down to under 50 or in the US under 200. And then it starts going back up and starts building. So incomplete virologic response, meaning this person never suppressed. Or if you get a virologic rebound, so you suppress and you get down to less than 50, all right? And in WHO, some of the territories, I think the threshold viral suppression is less than 1,000. In the US is less than 200. But then eventually, after a time of suppression, you see the charts start to go up, where you get now an increase in viral load, crossing 1,000, crossing 10,000, in which case something is wrong. This person is no longer suppressed. Now, it is not necessarily always the case that this is the result of drug resistance, right? It is possible to have treatment failure without resistance, and that is usually as a result of poor adherence, right? Or things like drug interactions, right? So what do we do when we see this occur, either incomplete virologic response or viral rebound? So first thing, the definition of viral rebound or incomplete virologic response centers around 2 viral loads spaced across by at least, let's say 8 to 12 weeks, right? So that you don't diagnose viral rebound or virologic failure on one viral load in a certain range. You always repeat the viral load. If you have 2 viral loads, then that tells us, okay, we need to figure out what's happening. Is this a drug resistance issue? Is this an adherence issue? So you can see that this sort of flowchart on the right. First, you repeat the viral load. Then you do an adherence assessment on the client. Are they taking the medications correctly? Are they taking anything that can interfere with the activity of the medication? So drug-drug interaction, which is the third step. And if you've ruled out drug interactions and you've ruled out adherence issues, well, then it is possible that this is a true case of drug resistance. In some instances where it's available to do a resistance test, there is some debate as to when to do a resistance test. In the US, they would do a resistance testing at baseline before you start, and at regimen failure at any point. So first line regimen failure, second and third line, you do a resistance. In other territories, you will do, especially because this is resistance testing is not universally available, you do resistance testing at a regimen failure. Some territories will do that at any regimen failure, some will do that second line regimen. And now, before we go too far into this flowchart, I just want to draw your attention to the enhanced adherence counseling flip chart, which is something that was developed with PEPFAR, CDC, and ICAP, which gives us a framework that we would use in persons who we suspect to have potential treatment, we believe have virologic failure, to go through this process where you would give them enhanced adherence counseling every month and repeat the viral at the end of 3 months and assess the virologic response. If they and with just improvement in adherence alone, anywhere between 40 to 70% of persons will resuppress, right? So they had treatment failure, but not HIV drug resistant. If at the end of that process they are still not suppressed, then what we may have, as I said, a true case of drug resistance, and we can proceed to make a decision about changing regimen. If resistance testing is available, review all resistance reports, right? And that's why that's important. And based on resistance reporting as well as treatment history, because all this information gives us an idea as to what might be the likely resistance profile for this person, and then we can make a decision about changing medication and continue to enhance and to support adherence. So what does WHO recommend with respect to management of HIV drug resistance? So HIV has its first line recommendations, primarily now based on DTG, which is dolutegravir. But as we said earlier, MRF is still in this category. Our 82% of our clients are still on an efavirenz-containing regimen. So in the absence of resistance testing, if someone on a efavirenz or a nevirapine-containing regimen experiences regimen failure, as would be diagnosed by, two elevated viral loads above 1,000 copies, spaced at least 3 months apart, and in the context of adherence support and confirmation that this person is adherent, then we show this person has actual drug resistance. But then WHO has recommendations with respect to what we should do second. If someone is on a tenofovir-containing regimen with either efavirenz or nevirapine, then the recommendation is switch from tenofovir to AZT, which is a different drug, and switch from either efavirenz to dolutegravir, or from dolutegravir to a boosted protease inhibitor like atazanet virolopin, right? And the same is the case with nevirapine, right? There are other regimens that one might use, including darunavir as the boosted protease inhibitor. I won't do children infants as we don't treat infants very much at our center. Now, when we discuss resistance testing, what resistance testing does is actually identifies which mutations are present in the sample taken from the client, and which HIV drug resistance mutations are present in the sample of HIV that is delivered, and gives us a report stating, based on those resistance mutations, what is the likely impact on drug sensitivity. So you see in the right part of the chart, you see this person a K65R and an M184B, sorry. And what that means, and so a K103 and these other things. So what that means is that, this person has high level resistance to drugs like abacavir, tembristine, and imivridine, susceptible to AZT, and intermediate resistant to tenofovir. Right? And you'll see on the other part, high level to efavirenz, high level resistance to nevirapine, but some drugs are spared. Right? And you can use this information to construct a regimen, and that will let you know, well, okay, well, I'll use drugs A, B, and C, but I can't use drugs D, E, and F. And this, once these mutations are present, they're present forever. So even if subsequently we repeat the resistance test and we see nothing, we know that these resistance mutations are there in the background. But the reason why they may not be there is that the resistance testing only detects variants that comprise more than 10 to 20% of the total viral population. I remember if you go back to our slide about what happens when someone stops medication, even if they have drug resistance, the wild type takes over, and wild type has no mutation. So you may well see someone who you know has drug resistance because you've seen this resistance chart already. And when you repeat the resistance test, you're not seeing anything because they've stopped medication and all you're seeing is wild. And that's another reason why resistance testing is most useful within 4 weeks of ART discontinuation, because in that 4-week time, you might still be able to detect resistant strains at a rate that is high enough to actually detect. And for most standard assays, the viral load must be somewhere between 1,500 and 1,000 copies in order to actually get a result. And as I mentioned before, we must consider prior resistance test results. If someone has had 10 resistance tests, the combination of mutations that you have detected is the complete resistance profile. And we would use that information to construct a regimen if the person is experiencing continued treatment failure. So this speaks to now what we do in third line, because when we speak about third line regimens now, this is someone who would have started medication first line, first set of medication they would have received, experienced regimen failure on first line, changed to something else, maybe not adherent to that, became resistant to that as well. So they now would have been resistant, now would have been exposed to at least 3 different classes of drugs, maybe more sometimes in some cases. So it now becomes a very difficult issue to construct a regimen empirically, because the chances that they will have a lot of complex resistance patterns. So WHO recommends, if you can, optimize the regimen using a genotype profile, but they still have sort of broad recommendations. So if someone would have experienced regimen failure, first on a dolutegravir regimen and then on a boosted protease inhibitor, but then you would think about going to darunavir, which again, high genetic barrier to resistance. Even if you had regimen failure on a protease inhibitor before, darunavir may still work. Right? You can go back to dolutegravir, even though that's what you were on before, but you would double the dose, right? Because you can still potentially overcome dolutegravir resistance by increasing the dose of dolutegravir. And you may use recycled nucleosides, right? And pretty much the same for if you were initially on a efavirenz-containing regimen, then dolutegravir-containing regimen. The good news is that because this person would not have been exposed to protease inhibitors before, then you would know they have good sensitivity to protease inhibitors. So you can use atazanavir, lopinavir, and you may still use dolutegravir. The benefit of using a genotype profile is that you would know, as in this case, for example, this person was on efavirenz, became resistant to efavirenz, but etravirine is still active, or pivirine is still active. So if we had to construct a 3-line regimen, if we had the benefit of resistance testing, we would know this person is still sensitive to etravirine. Etravirine is still a possibility. So you would have more options. Now, I want to speak briefly, because I want to make sure we have enough time to discuss our case, about a study called the NADIA trial, because this trial is kind of turning on its head what we thought we knew, what the WHO is recommending in terms of what I just discussed in terms of treatment profile. So so the background of this study, WHO guidelines had recommended, efavirenz and 2 nucleosides as first-line regimen, and when that regimen undergoes treatment failure, then the second-line regimen would be dolutegravir and 2 nucleosides, like lamivudine, zidovudine, or a boosted protease inhibitor plus lamivudine. And there was no resistance testing before second-line treatment, according to WHO. Just go right ahead and switch, right? But you would do a viral load monitoring at the time of switch. Now, what was the NADIA trial? So let me just go to the next slide. In the NADIA trial, they were trying to figure out, well, what is the evidence base for that recommendation? Can we actually interrogate that? We actually interrogate that recommendation. So in persons who were receiving a tenofovir-based non-nucleoside regimen, so for example, tenofovir efavirenz or tenofovir nevirapine, and had treatment failure on that regimen, so we must be on treatment for at least 6 months, and had again 2 viral loads above 1,000. We would randomize those persons either to get dolutegravir plus or darunavir ritonavir, and then a second level of randomization, either dolutegravir containing arm and darunavir containing arm are randomized either lamivudine, zidovudine, right, which is what WHO recommends, right, or they stay on tenofovir. Now the WHO had said switch off tenofovir because there's a possibility that there's resistance to tenofovir, so switch them. So the question was, what would be the outcome? You would think that zidovudine would have at least as good an outcome, or maybe even better outcome, because we're saying someone who's not tenofovir might end up becoming resistant to tenofovir. Going to change them and doing better, right? So we're trying to see, it was a non-inferiority trial, both to dolutegravir versus darunavir, ritonavir, and zidovudine to tenofovir. So at 48 weeks, dolutegravir was in fact non-inferior to darunavir, but there were some cases of dolutegravir resistance developing at regimen failure, which is not the case with darunavir, which is important, right? and tenofovir was non-inferior to zidovudine, which was fine. So they continued follow-up for 96 weeks, right? But at 96 weeks, what they found was slightly different. So if we talk about the baseline characteristics for the trial, it was equally balanced pretty much across the board. So dolutegravir versus darunavir is 59.6 male, female sex across the board, so between 59 and 61, median age in the 30s. Most of the persons were from Uganda, some from Kenya, Zimbabwe, Rwanda, and Mozambique. The median BMI, again, low 20s. Less than 5% hepatitis B. This was a cohort with fairly advanced disease. So, almost or slightly more than half of all the people who participated had CD4 less than 200, which is AIDS defining, right? And the median CD4 was low 200s or less than 200. And the median HIV RNA was, log 4, meaning 10,000 plus. And, about a quarter across the board had viral loads above 100,000. So in terms of time on ART, averaging about 3.6 years. Again, about 6% of them would have previously received a zidovudine-containing regimen. And this is particularly interesting. So about nearly half across the board of persons in the trial who had this K65R mutation, which is important because that's the mutation that wipes out tenofovir, right? If you go back to this slide here, K65R takes out tenofovir almost completely, right? So the only reason why we're not seeing high-level resistance to tenofovir is that the M184 kind of makes HIV a little hypersensitive to tenofovir, but absent that mutation, this resistance, as we say, high-level resistance to tenofovir, don't use it. But in this trial, half across the board were coming in already resistant to tenofovir, which makes you think, well, tenofovir should be really, really badly, but at the 48 weeks, it was non-inferior, right? And lots of 85% plus resistant to lamivudine and MRFTT. And based on the same algorithm we spoke about, so about between half to 60% of persons are expected to be resistant to tenofovir at the time of regimen. So about 20% resistant to zidovudine and high levels of resistance to lamivudine across the board. But at week 96, you can see that comparing dolutegravir to darunavir, so reading down the first two columns, HIV RNA less than 400, 89.8 in dolutegravir, 86.9 darunavir, no difference. Viral loads above 400, 8.5 versus 10.9, again, no difference. When it comes to tenofovir versus zidovudine, 91.8 of persons on tenofovir, either on the dolutegravir or darunavir, have viral loads less than 496 weeks. And 196 persons, which 84.8 of people on zidovudine are suppressed to less than 400. And the difference was actually significant, right? Less than 0.2, 0.02. So just below the threshold for significance, but below the threshold. And if you go compare dolutegravir to darunavir, going right down either side, whether it's less than 1,000, less than 50, same if you compare dolutegravir to darunavir. But the main difference is that in persons who rebounded above 1,000 copies, there were 7 cases of resistance, and it's all dolutegravir. So, which is slightly concerning. In other words, persons who were failing on dolutegravir were failing with drug resistance, whereas persons on darunavir were not failing with drug resistance. Right? And same thing on this side here. Now, another important line here is that there were significantly more persons taking zidovudine who experienced viral rebound at the fourth row across above 1,000 as compared to tenofovir, which is completely counterintuitive, right? Because again, based on this previous slide, 50 to 60% of persons going through this trial are expected to be resistant to tenofovir, but yet you're actually getting better treatment outcomes on tenofovir versus zidovudine. Right? And this essentially, comparing dolutegravir to darunavir, essentially the same right down. and ZW into tenofovir. You're seeing in some cases here where tenofovir is actually performing better, right? If you see left of that axis, ZW is better, so it's tending towards being better in a couple of cases. It is in fact outperforming ZW, which again is counterintuitive. So what essentially told us is that dolutegravir 2 nucleosides was just as good as darunavir 2 nucleosides, regardless of if those nucleosides are tenofovir or zidovudine, but a treatment failure with dolutegravir, there was actually failure with resistance in 7 cases. And tenofovir was actually superior to zidovudine in this context, which overturns in what we expect. So WHO may change their recommendations based on that. All right. So in summary, drug resistance can develop into multiple mechanisms. Early identification is important and essential in reattaining viral suppression and preserving treatment options. And treatment strategies for the management of drug resistance are evolving as research in the field advances. And that is the end of the presentation. So I'll just open the floor for any questions if anyone has them. Okay. Not seeing any questions. Or if you can't chat, if you can't talk, we'll chat in chat box as well. Right. But either I was clear or I was completely confusing, so I apologize. So if no questions, I'll go. Sorry. Oh, yeah, David, go ahead.
Okay, Gregory, thanks so much for that beautiful presentation. One other thing which wasn't mentioned is the fact that HIV type 2 is naturally resistant to NNRTIs. So if you start somebody on efavirenz when they have HIV type 2, the viral load will not be completely suppressed. And then you've talked very well about the role of K65. For quite a while, there's been a lot of talk about M184V reducing the viral fitness. And then what I've come across a number of times of late is that the K65, though it confers some resistance, but it also leads to viral unfitness, if I would call it that. And so the other ARVs, including tenofovir, still remains effective in terms of treatment. So I'm just wondering, when you combine the effects of K65 and MV184, is it that the changes brought about by MV184 makes tenofovir still effective, and the changes brought by K65 make lamivudine effective, and so Truvada still remains effective? Or what really happens, if any idea?
Right. So prior to the Nadia study, I think once we see K65, we say, okay, tenofovir is gone, we can't use it anymore, just move on to something, right? But some of that would have been, some of those studies may have been done on some of the older drugs. Right? The Nadia trial was done specifically on 2 very potent drugs with high genetic virus resistance, right? Darunavir and dolutegravir. So yes, we know that a lot of the mutations that confer resistance to nucleosides like AZT and D40, all those terms I didn't go into because that would have probably gone on too long, do have a fitness hit when it comes to HIV, right? So the virus, in becoming resistant to all those drugs, ends up becoming so mutated that it isn't able to replicate as efficiently as it would normally. So I think once the K65R mutation is there, even if it's M184, I think AZT is still fully active, we can go ahead and use it. The Nadia trial is suggesting that even in the presence of K65, as was shown in this study, 60%, I think, were resistant to tenofovir. If you pair it with another drug which is a high genetic barrier to resistance, important, like dolutegravir, darunavir, right? And keep lamivudine going, even if there's an M184, because keeping the M184 around gives the virus um, makes the virus less fit and more susceptible to the other nucleoside passing regimen, specifically to tenofovir and AZT. So it's interesting. I suspect that WHO may change their guidelines in the next iteration, given the data, especially 96-week data, that is now showing tenofovir is outperforming AZT, even in the face of high levels of expected resistance.
Okay, thank you so much for that. Now, when you look at the American guidelines, if they have a viral load, actually, even if it is less than 50 but detectable, they start raising some concern. And if the viral load is above 200, even 201, 202, they think that such a patient is potentially tending towards treatment failure. But WHO's guidelines seem to be quite relaxed in saying any viral load below 1,000 is suppressed.
Right.
And it's like if it is over 1,000, then you should start getting worried.
Mm-hmm.
Is it which is which?
Right. So honestly, so I remember trying to figure this out myself, right? Because the Americans say one thing, WHO says something different. Now there is evidence to suggest that at viral loads of 200 or greater, I think the first paper was Pedro Khan, I think, that at viral loads above 200, there's actually as opposed to less than 200, there is a statistically significant difference in rates of HIV progression as low as 200, right? Once it's sustained above 200. So I believe that's where the Americans come down on this, right? That even though the rate of progression might be slow, if there's a difference in progression rate, then rather than wait for this person to eventually get higher and higher loads and then have to potentially get more resistant and lose for your treatment options, sustained values above 200, you take them. Not valid, you change your regimen, right? You may not may or may not have access to the resistance testing at values that low, but again, I didn't mention this presentation because it, it has still got over time despite my best effort. You can, for example, get HIV genome from peripheral mononuclear cells and sequence those to detect HIV virus and have very low viral loads, and that may be used to direct treatment. Right? Between 50 and 200, again, persistent and sustained, I think it's reasonable to monitor. WHO comes down differently on this because remember WHO thinks with a very public health focused lens, particularly for parts of the world that are resource constrained, right? So in the background and rationale for why they still kept 1,000 as their cutoff point in the most recent iteration of the guideline, they speak to the fact that at values less than 1,000, the rates of HIV transmission are low. Right? Remember, they have changed the language recently to state that viral loads, undetectable viral loads, the whole inclusive paradigm. If virus are undetectable, you cannot pass on HIV. With virus less than 1,000, the chance of passing on HIV are extremely low, right? And that is the case, right? It's quite low, but detectable, right? Now, if it is in fact the case that at virus less than 1,000, there is very low rates of HIV transmission. If it is in fact the case that the rates of progression with virus above 1,000 are still quite low, right? That if we're making a recommendation for everywhere, meaning New York as well as Dar es Salaam, as well as Sub-Saharan Africa, as well as everywhere else, where
Yeah.
there may be limited access to some of the more expensive drugs, then practical, how much is what's the magnitude benefit by switching as low as 200 versus 1,000? What's the incremental benefit? And if it's not significant, then they came on instead of staying at 1,000.
Okay, thanks. Thank you for that.
So again, despite my best efforts, I've gone over time. I don't think we have time to properly discuss the case I'd like to present. So I think I'll put this case in my pocket for the next session, because it is quite an involved case. I just want to again thank everyone for coming out. Was there anything else we need to discuss with respect to the new IFO? Coming as we like to sensitize today?
Yes, definitely. So MRFTT is going to be starting a new iEcho platform. I think this is going to really kind of take the ECHO into another trajectory. It will allow for persons, once they come on, to kind of fill out a database form that allows every time they come into the platform that they don't need to re-register each time. But what this will do is that it will give you access to an entire database of all of the didactics that we would have done in the past, together with all of those cases that we're going to discuss in the future. It means that at any point in time, you'll be able to access them, especially the case discussions that we would have done, which we obviously can't share on YouTube. So this will give you access to those in a more secure way that would allow you to have, again, just access to these sensitive case discussions. We're really excited about when we move over to that platform. And so between now and January, we'll be giving you more information with each ECHO session that we do until we actually do the launch sometime around March, which would essentially just mean you filling out a form with some basic information, what treatment site you're at, that kind of stuff, what your profession is, to be logged into the iECHO the very first time. And after that, you'll get automatic reminders about all of the different sessions, access to the database and things of that nature. So look out for more information every week as we kind of guide you to this transition we do over to iECHO. Thank you very much. That's it from this end.
All right. So I think we'll have a slightly early date if there are no other comments or questions or contributions. I think we'll have an earlier end today. I'll keep the case in my back pocket until the next time we see you. Thank everyone for coming out, and thank you for joining us at the the beginning of the first ECHO session for the financial year. So our next session will be in 1 month. We're having it every 4th Friday.
That's correct. Every 4th Friday of the month.
That will be the the 4th Friday of the month is the 22nd. I wonder.
Yes, so we're not going to do it on the 22nd. I think what happens is we return to ECHO after Christmas, so we'll have it.
And 26.
It'll be the 29th because that'll be too close to Old Year's Day, Greg. I think we might be having 2 sessions in January.
All right. I'll be good by it. All right.
Yes.
All right. Well, thanks everyone again. Sorry. Go ahead.
No, that's it. Thank you.
All right. All right.
Thank
Take care,
you,
everyone.
gentlemen. Bye-bye.
Okay.